This is video 13 of the Safe Recovery Training Program, Identifying Strategies and Setting Goals. I'm Terry Haines. The objective of this video is to learn techniques to assist patients to identify strategies that will reduce their risk of falling, and to learn how to set goals with patients in the context of the Safe Recovery Program. The Safe Recovery Program, again, is set up through an information gathering and an information provision and joint problem solving phase. We're now up to the second last stage of the information provision, identifying strategies and setting goals. When identifying strategies, start with trying to prevent the fall that the patient thinks is most likely to happen to them. Ask them, what can you do to stop this fall from happening? The hypothetical activity that we did in the self-learning activity number 1 and that we do as a part of providing the Safe Recovery Program is a very important strategy that we use to help patients focus their thoughts on identifying the most relevant strategy for their own personal circumstance. When we went through this process in the trial based at the Princess Alexandra Hospital in Queensland, we recorded the goals set by 280 patients. 142 of these patients set goals around asking for help. 131 patients set goals around identifying environmental hazards around their room or ward area. 97 patients set goals around using walking aids and other aids. 71 patients set goals around waiting for help after it had been asked for. 38 patients set goals regarding using safe footwear or clothing, and 34 patients set goals about enhancing their participation in exercise therapies that they were receiving. The question that this raised for me was, why was the environmental hazard goal so high? If we go back to some of our earlier videos, you'll recall that some patients may not identify for themselves goals that are necessary and clearly apparent to you. They will instead want to blame environmental hazards and other external causes of falls that don't put the responsibility of decision making, choosing to do activities that are too hard for themselves as a centerpiece of their falls prevention effort. What I would advise is that after they have set their goal, if it is regarding an environmental hazard, let them do this, but afterwards you might gently need to guide them in the direction of setting goals that are potentially more relevant for them and their activities. So let them have their go of setting a goal about the environmental hazard so that they can lay the blame at that hazard, and then you can assist them to just sneak in another goal, even if you're using the do it for me approach for another activity that might be relevant to them in terms of enhancing their safety while in the ward. The most important strategy, of course, is to get people who need help to mobilize to ask for help and to wait for it to arrive. This is a centerpiece of the 3 simple steps to stopping falls. To achieve this, we need to establish where patients sit within Framework 3 and address negative factors that might impede asking for help. As you'll recall, Framework 3 was centered around the process of asking for help and waiting for help so that activities are performed with assistance so as to try and prevent falls from occurring. The range of different factors that could impact on a patient's willingness to ask for help have previously been presented and discussed at some length, and again further information on these factors can be found in the publications that have been cited in previous videos. For now, we're going to concentrate on a few of the biggies. The biggest one for me to begin with is resolving negative past experiences that patients have encountered when asking for help in hospitals. When dealing with negative past experiences, it's important first and foremost to listen to what that experience was, and then acknowledge both the event that took place and how this made the patient feel. Validate the patient's feelings. Then reflect. Use reflective listening techniques to help the patient to know that you've understood how they feel. This will go a long way to helping the patient to feel like you are on their side and that you are there to help them and not just be another person who's going to tell them off. Then respond. Get them to focus on what can be done now rather than dwelling on the past. Dwelling on the past will not assist them to have a safe recovery in future. There will be other practical things that they will be able to focus on to enhance their safety while in hospital. But it's very important that you listen, acknowledge, and reflect first before you respond. With patients who have a very strong desire to be independent, again, listen. Determine if they want to be independent for themselves or so that they won't be a burden to staff, because the response is a little bit different. If it's because they don't want to be a burden to staff, then that's something we're going to deal with in a second. If it's because they want to be independent for themselves, then acknowledge this and congratulate them. Say something along the lines of, oh, it's commendable that you want to be independent. If every patient was as motivated as you are to be independent, then we'd be a very efficient healthcare system. I'd be one of the greatest staff members, being able to get my patients so fit and healthy because they have such a strong independence drive. But redirect the patient. They need to be patient in the short term. We're asking for behavior change for only a couple of days to begin with until the first review of goals. And again, this is one of the key differences between the hospital setting and the community setting. Trying to use an approach based on goal setting in the community might have its limitations because you're asking people to pretty much change their behaviors for the rest of their lives. But in hospital, you're only bargaining for a couple of days worth of behavior change at a time. Get the patient to focus on their long-term independence. They might have to sacrifice a little bit of their independence now in order to guarantee their independence in the future. Highlight to the patient the potential threat that a fall could have on their independence in the future. And again, this is why having an appropriate level of threat appraisal is critical. You can also get them to focus on the effect that a fall might have on the patient's leverage point. So if they want to be able to get home so that they can help their neighbour with their garden or whatever the case may be, highlight that if they fall over while in hospital, it could directly threaten their ability in future to go home and do that sort of thing. The next issue that we're going to deal with is patients who have a belief that they can perform the task without any help. This again comes back to framework number 1 and the ability for patients to change their behavior to engage in risk compensation. It's very common to find someone who needs assistance who thinks they don't need it. And this is not surprising because patients have been doing things like going to the toilet, getting dressed, looking after themselves for many, many, many years. And this might be the first time in their life that they've actually needed help with some of these activities. So for some patients, it's going to take a dramatic change in how they view themselves and their own abilities in order for them to become accepting of the notion that they might need help to do these simple things. The first thing we need to do with these patients is evaluate. Do they recognize the impairment that they have? Do they have that intellectual awareness of what they need help with? Questions such as, tell me about how you feel about your walking, instead of, so do you think you have a problem with your walking, will likely give a more revealing and open and honest response. You may need the patient to compare again to their pre-morbid ability. So you say you can walk that far on your own, but can you do it as well as what you normally do? Is it the same as what you used to be like, or is it different? And again, that usually leaves the door open for patients to acknowledge that they're walking, although they might not see it as a problem, they will recognize it as maybe not be as good as what it used to be. The next thing we need to consider is whether the patient understands that their mobility impairment will impact upon their ability to perform an activity. So again, do they have that anticipatory awareness. The intellectual awareness says, yes, I have a problem with my mobility. The emergent awareness says, yes, I'm having a problem with trying to perform this particular task while they're performing the task. And anticipatory awareness is that I'm going to need assistance to perform this task in future. And really, it's that anticipatory awareness which is what is critical and often missing in a number of patients. Psychology student that I've been working with, along with some other staff, Renee Stolwick and Jenny Ponsford from Monash University, have recently developed a scale of self-awareness of falls risk, and that's been published in the Archives of Gerontology and Geriatrics. And it's an interesting way of looking at how much patients are aware of their own risk of falls with performing a range of different activities. Now, if patients do not have the intellectual awareness of the problem, that they don't even recognize that they have a problem with their mobility, then bring in the opinions of others, not your own. So say, what has your physiotherapist or nurse or occupational therapist said? Why do you think they said that? And contrast this with other activities of similar difficulty that they may acknowledge that they have a problem with. If they still don't admit to difficulty with any realistic task, you may require them to have a reassessment of their mobility with their treating nurse or physiotherapist or occupational therapist. And while they're having that mobility assessed, that therapist may need to have the instances where assistance is required re-highlighted to the patient. So when I worked as a physiotherapist, I would hold on to a patient using a walking belt while the patient walked around, and I would say to the patient, listen, did you feel that? I had to save you there from falling over onto me. There are a number of conditions such as stroke and other neurological disorders which can limit the ability of the patient to be aware that they're losing balance or that their walking is unsteady. So this may help them to become re-aware of the problem. The person providing the safe recovery program is generally not the person, and during the research was certainly not the person who would perform this particular task, however. Leave that for the treating team. If the patient does have an intellectual awareness that they have a problem, but not anticipatory awareness that they will need help to perform an activity because of that problem, then you can discuss with the patient why this may be the case. So say something along the lines of, you acknowledge that you are having problems with your walking, but you do not think you need someone to help you to walk to the toilet. Can you tell me why you feel this is the case? And again, use a very open discussion approach with patients to try and understand their perspectives. Again, the video has been designed to raise the perception of risk with innocuous activities by the bedside. You may need to reinforce this message with the patients, and you can highlight that many people who fall or who have fallen in hospital in the past did not think that they were at risk of falling while performing that particular activity. Patients who think they're going to be safe with performing these activities are also people who have fallen over performing those activities in the past. Now, some patients have difficulty believing that bedside activities can be high-risk activities. So you can show them the figures again that are contained in the video, or just verbally reinforce them. You can also, as a strategy, discuss the issue of risk compensation with the patient. And I found this to be useful, particularly with some patients who are particularly on the ball cognitively. You can say to them, well, the reason that these activities are dangerous is because you think they're not dangerous, and therefore you don't ask for help, and you try to do them without help. And it's because we compensate for activities that we think are dangerous, like walking to the toilet, that we're less likely to fall over performing those activities. However, some patients are still very unwilling to admit to being at risk of falls and may be in denial about it. Again, discussing the issue of falls and having people accept the notion that they may be at risk of falls can create a cognitive dissonance in their mind, and they may want to just shut down that conversation to deal with that problem. For these patients, again, use the do it for me approach. The next issue that you might encounter is patients who not want to be a burden for the staff members caring for them. Some patients really like to be good patients. They can see how unwell or disabled other patients are, and they recognize how busy nurses are and do not want to add to their workload. They can see how rushed they can be and how many tasks they have on their list of things to do. Every time a nursing staff member says to a patient, I've got to do this, then I've got to do this, then I've got to do that, and then I've got to come back to you, just reinforces in the patient's mind that the staff are busy. And for some patients, they won't want to add to that list of things for the staff members to do. Now, you can ask patients directly if they feel like they are a burden to staff if they ask for help. If this is the case, then redirect the patients. Use their desire to not be a burden to change their behaviour. Inform them that people who fall over create much more work for staff, both at the time in terms of getting them off the floor and the paperwork for incident reports, and in the future because it might delay their discharge and mean that the patient has to be cared for a lot longer and more and be supervised more closely for days to come. Again, for this to work, threat appraisal is critical. Patients have to believe that they're at risk of falling over. Something you might say to a patient is, it's better to spend 30 seconds helping a patient to do a trivial task by their bedside rather than an hour writing out incident reports if the patient falls, let alone any injury to the patient. The next issue that you might encounter is a lack of trust in the health professional who is caring for the patient. And again, this could be related to negative past experiences. I would advise that you manage this issue the same as for the way you manage negative past experiences. If patients think that even if I did have a nurse with me, they still wouldn't be able to stop me from falling over, they're the ones who create the problems in the first place, then cite the data that in a majority of falls, people are not being assisted by staff. Rarely do people who have a staff member with them fall. Now, it does happen, and it's happened to me while I've been assisting patients directly. I must admit I was distracted at the time by some whiz-bang wheelchair that a person was driving around in, and so was the patient who had had a stroke who I was walking with at the time, and they fell the opposite direction as the wheelchair drove past. So it does happen, but in the majority of cases, it doesn't. So do spend the time to talk up the competence of staff and their willingness to help. Tell patients that yes, the staff are here to help. They do want to help you have a safe recovery, and they are very good at their job. They can help you. Yes, we all have bad days from time to time, and patients may challenge you on this based on their past experiences. But the end conclusion is always, for me, that they're still likely to be better off with the staff member beside them than without. The final aspect of Framework 3 that I wanted to discuss regarding problems that might arise is a situation where a patient has been caught out doing something without the help that they've been told to wait for, and where this may have led to relationship breakdown, embarrassment, fear, and then secrecy and concealment. The first thing in this situation is to forgive. Tell the patient you're not in trouble for doing that. You may need to mitigate the initial staff reaction to chastise the patient though, and from the information we've received from patients, we know that they feel like they are being chastised by staff when they've been caught doing things on the ward that they're not supposed to be doing. The next step is to normalize this. Tell the patient you're not the only person to do that. Many others have done so in the past. You're not Robinson Crusoe here. Tell them that the problem is that it increases their risk of falls and hurting themselves, and that's what you don't want. The next step that I find is useful is to declare your priorities with the patient. The only reason I bring this up is because we all want you to have a safe recovery. I don't get paid any more or any less depending on whether you fall or not. For this, the patient needs to feel that there is genuine concern for their well-being, both from the organisation and from yourself. It's critical if you hope to restore the relationships or if you then want to use the do it for me strategy. When it comes to motivating patients to perform activities, the COM-B model that I discussed in Framework 4 as being a way to understand why staff perform certain activities and not others can also be applied to patients. And for some patients, the motivation to avoid falls is very low. So in dealing with patients who have a very low desire to avoid falls, again, this may be related to depression or other mood disturbances that the patient might be experiencing. These patients sometimes recognize and accept their risk of falls, however, they still just don't care. With these patients, see if you can identify a leverage point and illustrate the effect that the fall might have on that leverage point. Your only other strategy that you have left is the do it for me strategy, if you can't identify a leverage point that might work. Another factor with the COM-B model that we can consider is providing opportunity for patients to ask for help. Some patients have reduced capacity to deal with the hospital environment, and the way we set the environment up for patients may not be conducive to giving them opportunity to ask for help. We leave buzzers out of reach of patients. As a member of the team who provides a safe recovery program, I think it's important that we do identify short-term solutions, pragmatic small-scale changes such as giving a nursing buzzer to the hand of the patient, or removing clutter from the patient's bedside environment if it's easier to do so. For long-term solutions, you might need to work with hospital staff and management to try and bring about changes to informal and formal procedures that may be leading to problems or restricted opportunities for patients to ask for help. Larger scale environmental changes may also be possible working through these systems.